Hi, I'm Ken Anderson here at ASCO in 2013 in Chicago, and one more year. It's very, very exciting here in multiple myeloma. We have actually the drugs that we've come to know over the last decade continually advancing. In particular, we have data here for the new immunomodulatory drug pomalidomide with low-dose dexamethasone. That actually was recently granted accelerated approval because of the response rates in 30 to 40% of patients, durability on the order of 8 months average, and then patients living years. So we have an expansion of that pomalidomide low-dose dexamethasone experience here, honestly in combination with some of the first-generation novel agents and some of the second-generation novel agents. So for example, Velcade, the first-generation proteasome inhibitor, is being presented here combined with pomalidomide low-dose dexamethasone with approximately 80% responses in the relapsed multiple myeloma setting. There are combinations of the two novel agents. So we have pomalidomide low-dose dex, as I've just mentioned, being combined this time with the new proteasome inhibitor, carfilzomib, that was also recently FDA approved almost a year ago now in the summer of 2012. And here again, carfilzomib and pomalidomide low-dose dexamethasone is a very, very high response rates. The one caveat that we need to remember as caregivers and patients is that when we combine these new agents together, which are very much more potent than the first generation agents, we have to be very careful. We certainly want to escalate doses to increase efficacy, but we have to watch out for side effects. Now, I think if you had to look and say, what's the major excitement this year at ASCO in general and the potential for multiple myeloma, you have to say it's in the immune therapies. Data being presented at this meeting with antibody to PD-1 and antibody to CTLA-4 put together to really, as I like to say, take the brakes off of the immune system is remarkably active in metastatic lung cancer, in melanoma, and other solid cancers. And this is very early data, but we're talking 2/3 of the patients responding or more. So the excitement here is that in multiple myeloma, we know that myeloma cells also make PD-1. We know that these same mechanisms are putting the brakes on patients in multiple myeloma. So I think we can expect clinical trials in a very similar fashion very soon now to examine the value in multiple myeloma that has been so exciting in the solid tumors. Already here, and I'll finish up with this, are the monoclonal antibodies, which really are a strategy of immune treatment. Elotuzumab is here, having been combined with lenalidomide and dexamethasone to increase its efficacy. And remarkably, in relapsed multiple myeloma, when lenalidomide dexamethasone achieves 11 months of progression-free survival, elotuzumab lenalidomide dex is now approaching 3 years. So a major difference, 2 to 3-fold increase or increment in progression-free survival. And the second antibody or target is called CD38. And the furthest along in targeting CD38 is an antibody called daratumumab, which is similarly achieving remarkable responses. And the excitement here in the immune treatments is that even multiple myeloma, which has adverse genetics, either starting with adverse genetics or acquiring adverse genetics over time because of multiple relapses, should be susceptible to these immune approaches. And you can see the day coming soon where we will be combining immune therapies just as we combine novel targeted agents today. So one more time, I just would say that it's in Chicago. The Cubs are here. Eventually they will win the World Series. Eventually we will win against myeloma. But we have remarkable progress to report once again this year.